For a case of rhinorrhea or runny nose, using our mnemonic old cards, we note the onset, or when did it start. For duration, we want to know if the runny nose is occurring constantly throughout the day or notice intermittently when going outside or being around pets. And then next, we can note the progression. Does the runny nose appear to be occurring more frequently? To characterize it, since it is a bodily fluid, we're going to use our mnemonic A, B, and C to write down for our patient note the amount, if there's any blood, and the color. And since this is a poem case, we could ask now or later in our review of symptoms of any other upper or lower respiratory tract signs, such as a cough, sore throat, or shortness of breath, aggravating and alleviating factors, and treatments tried. For all cases, we should order a CBC, serum electrolytes, and a respiratory viral panel. Allergic rhinitis is typically seen for the first time in those less than 20 years old, and non-allergic rhinitis in those greater than 20 years old. Our other supporting points will include a runny nose, sneezing, nasal itching, a cough, and since a cough is a bodily fluid, we also want to write down the amount, blood, and color, and then the sensation of postnasal drip or liquid dripping in the back of the throat. For a viral URI, which includes a common cold, sinusitis, pharyngitis, and laryngitis, we can see runny nose, a cough, a sinus pressure, sore throat, hoarseness, and possibly a fever. For bacterial URI, what helps differentiate a bacterial sinusitis from a viral sinusitis can include the time course if it's greater than 10 days, or the phenomenon of double sickening, which is improvement followed by a worsening. What helps us differentiate a bacterial pharyngitis from a viral pharyngitis include the Centaur criteria, or the presence of exudates, tender lymphadenopathy, an absent cough, and a fever. And for epiglottitis, we'd expect to see the 3 Ds, or drooling, dysphagia, and a respiratory distress. If we're concerned for a bacterial pharyngitis, we'll include in our workup a rapid strep test and a throat culture. In influenza, we'll see a runny nose, a cough, sinus pressure, sore throat, and now myalgias and a fever. And finally, in a pneumonia, we'll see a runny nose, a cough, dyspnea or shortness of breath, and a fever. And as we'll see in our physical exam coming up, a positive special test for Tactile Feminists and Egophony. And we'll include a chest x-ray and sputum gram stain and culture. We'll start the poem exam with hand sanitizer, and we want to ask our SP if we have our permission to examine you. Okay, after he said yes, we'll start with a hint exam. For the eyes, we're primarily concerned for conjunctivitis, for a URI, so we'll ask the patient to look up. So we verbalize there's no conjunctivitis, no parlor. Ask him to look down and verbalize no scleral icterus, no conjunctivitis as well. And then we could also quickly assess the nose to see if there's any rhinorrhea, if he has any runny nose or congestion. And we don't see it. And then we could go ahead and look into his oral pharynx. So we could do that with the tongue depressor. And we want to use very light pressure for these SPs. We don't want to cause them any pain, so ask them to stick out their tongue and say, ah, and we'll look around and say that there's no visible lesions. The oral pharynx is clear of exudate. On to lymphadenopathy, so we're going to go ahead and inspect his cervical lymphadenopathy. So we'll start over here. Next, we're going to go ahead and do submandibular, submental. Okay, we're going to do preauricular and postauricular, do occipital. And we want to do supraclavicular, so please shrug your shoulders. Okay, good. Okay, so we had no lymphadenopathy. We'll go ahead and look at his fingernails, and you don't see any cyanosis. We could press on his fingers, and we don't see any delayed cap refill. We also want to check for calf tenderness if we were concerned about a PE. So we could squeeze his calves and ask him if he has any pain. Okay, and we're going to introduce the Homan's maneuver. So it's when you ask them to dorsiflex, please. Please raise up your toes, and then we'll squeeze their calf and we'll ask them if they have any pain. Please raise up your toes again, and then do you have any pain on your calf? Okay. And now once we're finished down there, it's always a good idea to hand sanitize again. So now we can move on to the poem exam. And so for the poem exam, the best way to do this is to drop down the gown halfway and ask the patient to please sit across your arms here, and this will hold the gown and keep them protected. So the first thing we want to do is verbalize that there's no visible lesions to the anterior chest, to the posterior chest. Next, we'll palpate. So we'll palpate his chest and just ask him if you have any tenderness there or pain. Tenderness or pain. Do the same thing on the back. We could percuss. So we're going to go left to right, 3 spots.
listen to his lung fields. We'll use the bell of the stethoscope for his above the clavicle, so we'll instruct you on instruct him every time you feel the stethoscope. Please take a breath in and out. Okay, that was a good equal breath. Now on the other side, so please breathe in and out. And you'll notice here that this time you don't notice a breath coming in and out of him. Instead, you'll notice arm shrug. So please do that again. You can see it again over there. So as we move on to the diaphragm now for his lower lung fields, please. Okay. And again, we don't hear a breath, and instead we see the arm shrug. I'll go ahead and do that for the last lung field, please. Okay, good. So that was a good breath. And we see the same thing as well. And now on the posterior side, we'll do the same thing. We'll listen in 3 spots, comparing left to right. So please, you see the arm move up and down again, and we don't hear a breath. On the right side, we hear a breath. The left, we see the arm move. Okay. So now that we completed the auscultation part, and we can make a comment that we heard clear breath sounds on the right, but on the left, we didn't hear the breath sounds. We want to go to tactile fremitus. And so the way to do tactile fremitus is to position your arms, your fingers around his scapula and ask him to please say 99.
99.
And you could, if you could hear him, it's a little hoarse. So that indicates that there's increased tactile fremitus. And now we're going to demonstrate egophony. So for egophony, you could use the diaphragm of the stethoscope, and you'll ask him to please say E. Okay, so we heard a clear E there. And now we could hear a transition to an A on the left side. We'll do the same thing for the lower lung fields. You hear a good E and an A. Okay, good. While we have him sitting up here, we want to use economy of movement to make use of the time and listen to his heart sounds. So the mnemonic we're going to use is the Parmet M225A. So we'll start off with his aortic in the second intercostal space on the right. Go ahead to this pulmonic, tricuspid, and mitral. And if this was a female patient, you could ask them to please lift up your left breast. Okay. Make a comment that we heard an audible S1, S2, no audible S3s or S4s or murmurs, rubs, and gallops.